Okay, so let's move on to another question. So you've got a 14-year-old who returns to your PICU after a posterior spinal fusion is intubated. As you lighten the sedation to perform a spontaneous breathing child, the child awakens and coughs violently. The capnography changes are shown below, and now the child is desaturated and wheezing diffusely on exam. What intervention is indicated? And so here's the capnography change. Here was kind of the normal pulse ox, and then all of a sudden the child coughed and began wheezing, and here's how the pulse ox changed. So do you A, suction the patient, B, remove the displaced endotracheal tube and reintubate, C, provide nebulized hypertonic saline to clear secretions, D, deeply sedate and paralyze the patient, or E, provide nebulized albuterol followed by sedation. Okay, and this is one just testing your recognition. So the correct answer is provide nebulized albuterol followed by sedation. And what we're trying to get you to recognize is that this ramping that all of a sudden has happened is basically indicative of airway obstruction, right? And what's happened based on the history is the child has had laryngospasm and bronchospasm as a result of being too lightly sedated, and now you've got significant bronchospasm causing airway obstruction. So you want to deal with both the bronchospasm and also the underlying sedation issue that allowed it to happen, right? And that's why answer E is the correct answer, okay? Just sedating the child is not going to take care of things immediately, and some of the other ones really are just wrong because the waveform is not indicating extubation or other problems like secretions. So we're going to look at what capnography can do for you, but let's start with kind of some of the methodology behind capnography. So capnography is basically measuring CO2 content, and that's done based on ultraviolet absorption. And you can do it one of two ways. You can either capture, in this case, directly as the air is moving through. So this is considered mainstream sampling. So basically, as the gas is moving through the vent circuit to the patient, you're just measuring the ultraviolet within this cartridge right here. Or you can do what's called side stream monitoring. So these are both side stream circuits where here you see this small inlet into the breathing circuit that's pulling out a sample, and here it's a pulse ox nasal cannula, and again you've got a small amount of sample being pulled out, and that sample then is being delivered to a device that is taking the samples, shining ultraviolet light through it and coming up with a CO2 content. Mainstream in general is going to be more accurate and not pull off or divert any of your gas flow, but the problem is this does create some dead space, and so in some cases it just makes more sense to do side stream. What are the clinical uses of capnography? The identification of where the endotracheal tube is, whether it's placed in the trachea or not, is one of the main ones, and that's a major safety thing, and in several guideline statements like CPR guidelines, it's stated that you should use end-tidal CO2 to quickly verify that you're in the trachea. The capnograph waveform is actually quite useful, and we're going to look at an analysis of some of the things it can tell you, but airway obstruction is one of the big ones, like in the question. Based on what the relationship is between your alveolar CO2, which you're going to estimate usually based on your arterial CO2, and your end-tidal CO2, you can figure out how much dead space you have. So there's a dead space fraction calculation that can come from that. And then looking at the end-tidal CO2 kind of longitudinally correlates with essentially how well your patient is ventilating, assuming that other things are stable, and the major other thing is cardiac output. So end-tidal CO2 is actually dependent on both V and Q, right? So the V being ventilation and Q being the perfusion, but specifically we're talking about pulmonary blood flow. So if your patient's pulmonary blood flow is dropping off, whether that's because they're having a pulmonary hypertensive crisis or they're in a low cardiac output state globally, then what you're going to get is a depressed end-tidal CO2 because of lack of perfusion. So looking at the capnography waveform, this is just a kind of idealized look at it, and there's several phases that it gets broken up into. You've got your CO2 production, which is occurring in the lungs. Then you got ventilation that's happening, and so this is when the patient is inhaling, so there's obviously no exhaled CO2, so you're 0, and then all of a sudden you let out your breath, and so you have a rise in the CO2 as it's being exhaled out, and then it should stabilize. And really, sometimes this looks like a completely flat plateau, sometimes there's a very subtle increase, but generally speaking, this should be a tabletop, okay? And so phase 1 then is going to be indicative, if it's prolonged, is going to just tell you that you have a lot of anatomic dead space, because this is, if you start to exhale and you don't see the CO2 immediately rise, it's because there's so much dead space where no CO2 is present. Phase 2, on the other hand, the slope upwards is going to be reflective of your perfusion, because basically this is the transition from upper to lower airways. So, phase 3 is really telling you what's happening in your more distal or lower airways. And if it takes a long time to get up to this point, then that kind of tips you off that maybe you don't have great perfusion, so it takes some time for that flow to come out. And finally, the ramp on phase 3, if there's one present, should tell you that it's taking a long time to get the more distal airways, and so that implies obstruction or a low exhalation flow state. In terms of the correlation between PaCO2 and end-tidal CO2, it's reasonable, it's not phenomenal. You can see that there's quite a bit of fluctuation here. The R value, or correlation coefficient, is just 0.67 in this study. And so although you can use end-tidal CO2 as a metric or a rough correlate of PaCO2, if you're really worried about PaCO2, you need blood gas monitoring. And then it's important that giving bicarb is going to affect this, because as soon as you give bicarb to a patient, to some extent, depending on how acidotic they are, they're going to convert that bicarb into CO2, and that CO2 is going to be immediately released, right? And so this is an example of a patient who's actually getting bicarb in the setting of a code, and you can see that as soon as the bicarb is given, on the next few breaths, CO2 steadily rises, right? And so this is not that the perfusion got better. That would be kind of the wrong interpretation of it, but it's just the bicarb effect, right? The bicarb got turned into carbon dioxide gas, the carbon dioxide gas got exhaled, and then eventually it settles back out as the bicarb dissipates. So what's the impact of ventilation and perfusion? So different waveforms are telling you different things, right? So here we talked about what happens when you have obstruction of flow. So just to go through these 3 examples here, A versus C is basically the difference between having a lower overall CO2 but still having a stable flat tabletop. So this is just a lower flow state. So in this example, they're kind of showing you what would happen if you had a pulmonary embolism, right? Less overall blood flow, okay? On the other hand, B is indicative of if you had something like bronchospasm, where your perfusion is fine, but the problem is your flow is poor. And so in that situation, you start to see this ramping effect. So this is, lower overall, but flat plateau. End-tidal CO2 implies a low flow state, whereas a slope like this implies bronchospasm or slow exhalation. And so this is just showing you airway obstruction. Again, you see the slope. This is the trace that I showed before of cardiac arrest, but now rather than focus on the bicarb, what I want to show you is a difference between bad CPR, which is being done here, versus presumably better CPR, okay? And so in this situation, the end-tidals are stably higher than they were here, so you're generating more perfusion. And this may be the CPR, or in this case may have been the effect of the bicarb, but either way, it's better perfusion. And then notice what happens when you get ROSC. So this is actually very helpful in the setting of cardiac arrest, having quantitative capnography, because you can notice when you have return of spontaneous circulation, because immediately there's a big upshot of the CO2 because the perfusion gets so much better. The next thing here is just showing you the impact of changing someone's their positioning in bed on their end-tidal CO2 tracing. And this is just because of compressing one lung and adding or matching V and Q in different lobes of the lung. So depending on how you move a patient and what kind of lung disease they have, their end tidal CO2 may change, and it'll just tip you off what's happening to V and Q. So then let's look at some of the effects of things like ventilation and perfusion over time. And so here what you can see is what's happening to the slope. So as you get somebody being, in this case, it's a patient being placed on progressively higher PEEP. So this is a PEEP of 0, 3, 6, 9, 12. And essentially what's happening is as the PEEP is being turned up, their blood flow is decreasing some because PEEP is going to prevent preload, right? And so as the blood flow is coming down, notice that both the slope here starts to become more and more gradual, so less steep. And this is the phase 2 changes we were talking about. And then notice that where the actual plateau ends up also comes down, and that's the difference in phase 3 that goes with a low flow state, okay? In this case, what we're looking at is the changes in pulmonary perfusion with actual decreasing pulmonary blood flow. So they've experimentally changed the blood flow, and notice that these are pretty identical to one another, okay? And so essentially the changing of the slope and where the plateau lies tells you about blood flow. Now I mentioned capnography is a great way to confirm intubation. You don't necessarily have to have quantitative, right? You can just have qualitative, and that's the purple and yellow color change that we frequently look at. And within a esophageal intubation, you are often initially going to see some CO2, but then notice that very quickly it tapers down, right? So you might get an initial color change and all of a sudden it's gone, and that's your tip-off that you're dealing with an esophagus versus a tracheal intubation. And we've already alluded to the ability to use capnography as a surrogate for cardiac output. This is one of the, or a couple of the studies that have been done. You can see there's actually a very strong correlation between the cardiac output during, in this case, a passive leg raise versus the end tidal CO2. And likewise here, you're seeing a patient being put through a passive leg raise or volume expansion, and notice what the effect is. So during the passive leg raise, there's an increase, and so that predicts that the patient's volume responsive. Here we give them volume, and sure enough, the end tidal CO2 rises, okay? So CO2 is a good way to have a surrogate for cardiac output, and in fact, there is a device, at least one that I know of, called the EtCO2 that was being marketed. I don't know if it's still available, but it was a form of measuring cardiac output based on capnography. Now your capnography is going to be thrown off when you have vent dysynchrony, and so here what we're seeing is the patient making respiratory efforts in the midst of exhalation, right? So the patient's essentially trying to breathe but failing to trigger the vent, and so what you can see is that it's not smooth. So anytime you look at your capnograph and you see a whole bunch of kind of dips and things like that, it's just tipping you off that your patient has dysynchrony. And if you get these kind of interruptions in a smooth upslope of end tidal, that usually means that the patient's making efforts but not being rewarded for those efforts. So then you might want to look at your trigger or look for auto PEEP as causes of that.